All right, so we are the hip and knee joint by me, Emer, Hannah, McKenna, Abby, and Madison. So we're going to go ahead and get started.
Okay, so we're going to start by talking about the anatomy of the hip joint. So, from gross anatomy, we should all remember that the hip joint is also referred to as the acetabular femoral joint, which is a ball and socket joint and a synovial joint, allowing for movement in various planes. So, this joint in particular, the ball and socket joint, allows for 3 degrees of movement or freedom and allowing for flexion, extension, abduction, adduction, external and internal rotation. Um, and this joint in particular is the connection between the axial and appendicular skeletons. So it's going to be a big stability and weight-bearing joint. And then the center of access is going to be through the femoral head. And then we're going to have a connection of the femoral head and the acetabulum in the pelvic bone. And the femoral head is going to be covered in hyaline cartilage, encouraging smooth movements. And then the femoral head inside the acetabulum is enclosed by a capsule that's surrounding the entire joint. And this capsule is strong and dense because a lot of muscles are going to be reinforcing the stability as well as various ligaments. Um, the thickest portion of the capsule is going to be posterior superiorly, and the strongest is going to be anterior superior, since that's the aspect of the capsule that has the greatest amount of force placed through it. And then the weakest portion is the posterior inferior. And then again, like we said, this is going to be reinforced by various ligaments that we'll talk about in a few slides. Sorry. Okay, and then this slide is just kind of an overview of all the muscles. So we should already kind of be familiar with all these muscles, but basically they're grouped based on their function. So we have our hip flexors, our hip extensors, our hip abductors, adductors, hip internal rotators, and external rotators. And your muscles are going to mainly perform like one motion, but a lot of them provide additional support in various other um, planes. So we have like our gluteal group, our adductor group, our internal rotator group, which is our deep six, and our iliopsoas groups. But these muscles might also be contributing to other motions at the hip joint.
All right, so in terms of ligaments supporting the hip joint, we have the internal ligaments, the external ligaments, and also our labrum. So in our internal ligaments, we have the ligamentum teres, which is a pretty weak ligament. It attaches to the margin of the acetabular notch. Um, and there's a small branch of the obturator artery that runs through this area, which can get irritated with some movements or extreme ranges of motion. This ligament also provides some mechanical stability, just reinforcing that labrum. We also have external ligaments. So our iliofemoral ligament, or the Y ligament, is the strongest ligament in our body, just because of all the weight going through this joint and this area of the hip. This ligament runs under the iliopsoas tendon, and it prevents hyperextension of the hip and resists extreme rotation. Next is the pubofemoral ligament. It runs anterior and inferior to the joint. It's triangular in shape, and it limits abduction and lateral rotation. It is a big player in strengthening the inferior and anterior capsule of the hip. And then the ischiofemoral ligament is medial to the greater trochanter, but it's also deep to the Y ligament. It starts posterior and kind of spirals superior laterally to the greater trochanter, and this ligament resists medial rotation. Then we have our acetabular labrum. It is a fibrocartilage ring. It's poorly vascularized. So again, if this was injured, right, you can imagine healing time might take longer than other areas that are more vascularized. So this is where the joint capsule attaches to, is the labrum. It deepens that socket by 30%. And then its thinnest portion is the anterior aspect, which is where most tears occur. And then we have some nerve involvement that plays into the hip. We've all seen these nerves before. So the obturator nerve, sciatic, superior and inferior gluteal, and then the nerve to the obturator and quadratus. So here's just a great picture of seeing where these nerves go. We have to remember that this area has tons of overlap between the muscles and the nerves, which can cause irritation. We all know that the sciatic nerve is a big play in that. So just be mindful of that when you're treating patients. And then we have the common pathologies of the hip joint in this very clever picture that McKenna put up. I can't say I'm entirely pleased with my hip replacement. We thought you would like that, Dr. Irwin. So here are just some common pathologies. The labral tears, we've talked about all of these in class, piriformis syndrome, hamstring tendinopathy, et cetera, et cetera. A big one would to be mindful of is the avascular necrosis. This can present as a red flag in the clinic. So again, just knowing what to look for in terms of these pathologies.
Okay, so we're gonna start getting into some exercises now. So the first group of muscles that we wanted to target was the hip extensors. Mainly the gluteus maximus and gluteus medius are going to be our main hip extensors we're going to focus on because they are going to be the most dysfunctional that we'll see in the clinic and the best for decreasing risk for lower extremity pathologies and dysfunction and improving our mechanics. So these muscles are very important to strengthen so we can help overall support the body against gravity. So basically, some of the research articles we found said that bridges are going to be the best for targeting and getting the max isometric voluntary contraction of the gluteus maximus and gluteus medius muscles. So you're going to be in a supine position, hook lying. So the knees will be bent to around 135 degrees to target the glute max muscles. This number was just one that we commonly found in our research, but anywhere between 90 and this number would probably be better for targeting the glute max and gluteus medius muscles rather than your hamstrings. And then the toes off the mat into full dorsiflexion is also going to target these two muscles as well. And then dosing 8 to 12 repetitions for 3 to 4 sets, 2 to 3 times a week for strengthening purposes. And then again, like we said earlier, clinical applications, we're going to see a lot of weakness and imbalance in these muscles. So when we have weakness and imbalance, there's going to be associated with dysfunction up and down the chain. So by strengthening them, we can minimize the risk of lower extremity injuries. And then it's also been found that gluteus maximus strengthening decreases low back pain and disability. So again, up and down the chain. So anywhere, knees, ankles, low back. And then glute max and prone is going to inhibit and weaken or inhibition and weakness contributes to chronic pain and injury in the athletic population. So the doing glute bridges is going to help any population from athletic to the elderly.
Okay, so for the regression and the progression of our hip extension exercise we chose here, I know, as we all know, these are really commonly done in the clinic. setting. We see a lot of glute bridges. So we found in some of our articles that we chose this regression progression of difficulty and how it kind of correlates to how much of the glute max is being activated. So the articles we found were using max voluntary isometric contraction, which the breakdown of the direct evidence from the 2019 systematic review we found is shown in the table on the next slide. So one can progress the glute bridge to adding some sort of weight along the ASIS is along your hip. You use, like in the picture, the girl with the pink leggings, hands on the weight for support, but the arms shouldn't be doing any of the lifting. This is just pure hip extension. This extension of the hips against the resistance further challenges and strengthens the glute max. And you should also, when you're adding the weight, you need to make sure the patient is maintaining the proper form and positioning, like is shown on the previous slide, to keep the maximum gluteal activation and always keeping the neutral spine. So in terms of body weight, which is another progression that we went to, which is the single limb hip bridge, just without any weight. This is what the systematic review like overall really looked at, was just body weight hip bridges. So the single leg hip bridge shows 40 to 60% activation of the glute max, which is much greater than the double leg normal glute bridge we see, or the elevated one, which you see on the left as the elevated hip bridge is a regression we chose. So to progress the standard hip bridge, one can add weight, or you can perform a single leg hip bridge with one leg off the ground. And we found in 2 articles that modifying the traditional single leg bridge by flexing the knee to 135 degrees instead of 90 degrees will overall minimize the hamstring activity while maintaining high levels of gluteal activation. So I just thought that was really interesting, that the knee flexion angle really does give you a better overall activation of the glute max, which the breakdown of that is also shown in the next slide. We found 2 articles that stated that. So resistance bands can also be added to perform abductions to really get a better glute med activation. And the single leg glute bridge can also eventually be progressed to adding weight as well. So you should always be keeping a neutral back and cueing the mind muscle connection to the patient to really make sure that they're thinking about contracting the glute max while performing the exercise, because that is our goal here. And regression of the exercise to the elevated. So the elevated hip bridge can either be on a sturdy surface or it can be on a Swiss ball, which would be a little less sturdy. But we chose to do this as a regression because in the systematic review we found from 2019 that the elevated position really does have a lower activation of the glute max. So it can be just an easier way to perform the exercise, or just get that glute max firing from the beginning so they can really feel it before they progress to another. And then on the bottom left, the quadruped flex knee kickbacks, which is we also from the same article, it stated how quadruped hip extension with the knee flexed has a range of about 30% max voluntary isometric contraction for the glute max. So we thought this could be a good regression. It's not a hip bridge, but it's still a hip extension exercise. So it can still really target the glute max and do hip extension if your patient is maybe not wanting to tolerate performing a hip bridge, or they can't do it correctly, or they just don't like that exercise. So doing this quadruped flex knee kickback can also be progressed to adding a weight behind the knee, or you can perform that with resistance bands as well. And so this is just the table from the systematic review that we added. This article is called Examination of the Gluteus Maximus Electromyographic Excitation Associated with Dynamic Hip Extension During Bodyweight Exercises. So I just highlighted a few important parts that I thought of this table that stuck out to me. So just what I talked about before, how we have the elevated hip bridge, which they looked at it on a Swiss ball, but that had a lower max voluntary isometric contraction. I highlighted the standard bridge, the single leg bridge, and then I also highlighted the single leg bridge with the 135 degrees of flexion with the dorsiflex ankle, which had more glute max activation than just doing a normal single leg hip bridge. So I thought that this showed a really nice progression of which bodyweight exercises produce more maximum isometric voluntary contraction of the glute max. And overall in this article, they found that the absolute highest excitation was in, which they were just looking at body weight, but the single leg bridge of up to 50% of the glute max. So I thought that was really interesting to know that that's a really good place you want to get your patients to be progressing to. This is just a list of the research that supports what we were just talking about in the last 3 slides.
All right, so the next exercise we chose to do involved hip abduction. So we chose to do clamshells, which target the glute med and TFL. And so the setup for a clamshell is what's in this picture in the lower left corner. The patient is just going to be sidelined with their legs stacked on top of each other. They will have slight hip flexion, knees flexed to around 90 degrees. And then throughout the motion, they're just keeping the feet touching and then just lifting that top knee up without letting the hips or pelvis rotate or move. And then just bring the leg back down, the knee back down. And so the dosing for this, we thought starting with 8 to 12 reps for 3 to 4 sets, and then doing that 2 to 3 times per week, and then just progressing from there. And so the clinical application that involved hip abduction, we found one article that stated that people with patellofemoral pain syndrome are more likely to have hip weakness than those who don't suffer from knee pain. And so this just supports the idea that hip abductor strength is important when it comes to knee health and stability. So as we know, the hip joint is pretty important in just any kind of movement. So dysfunction at the hip can affect things up the chain, so things like the lower back and just along the back, or it can affect things down the chain, so at the knee and ankle. So it's important to have that hip stability when looking at the entire body. And so this study also had a kind of a rehab program that went along with it. And that study found that after a 3-week hip abduction strengthening program, patients with patellofemoral pain syndrome increased muscle strength and displayed decreases in both pain and stride to stride knee joint variability. So it's just showing that the hip can affect the knee. And then another study found that hip abductor weakness is a predictor of future falls in community dwelling older adults. So we know how important the hip abductors are throughout the gait cycle. And so obviously just dysfunction with the hip abductors can lead to instability when walking. Another study found the effects on physical function after a total knee arthroplasty. So I just found that hip abductor strength influence physical function in patients following total knee arthroplasty more than quadriceps strength or demographic or anthropometric variables. So just another example where the hip can affect the knee joint. Another study found that glute med strengthening for the patients with meniscal surgery improved knee joint function recovery and pain. And this study also just talked about how important a rehabilitation program is and how it should be implemented early to help with that recovery. And then lastly, a study found that glute med weakness and gluteal muscle tenderness are common symptoms in people with non-specific low back pain. So this study found that the glute med is weaker in people with low back pain when compared to controls. They also found that the Trendelenburg sign is more prevalent in people with low back pain compared to the controls, and that there was more palpation tenderness over the gluteals, greater trochanter, and paraspinals in people with low back pain. So just another example of where dysfunction at the hip can cause issues in the back. And next slide. So this is just kind of talking about why we chose clamshells. So clamshells were pretty much mentioned in most research articles that we found when looking at exercises for the glute med. But it found, or most of them showed, that clamshells didn't necessarily have the highest percent max voluntary isometric contraction of the glute med, but it was always mentioned, and it was usually in that moderate range. So this was a systematic review that looked at EMG activation of the glute max and glute med when performing hip abduction exercises and external rotation exercises. And they found that the AMG activation greatly varied depending on the position, which we know if it's gravity eliminated or against gravity, and then the complexity of the movement. So I know this chart is kind of blurry, but in the green boxes are the different clamshells that were used. And so they found that clamshells don't necessarily produce the highest percent MVIC for the glute med when compared to other exercises, such as the one in the orange box, which is side bridges with hip abduction, or the one in the navy box, which is standing abduction with a band at the ankle. But it still does have glute med activation. But this study said that those are highly demanding exercises, so those would be potentially inappropriate for beginners or weaker individuals because they require more stability and just more strength. And so this is why the clamshells can be used to elicit that strengthening of the glute med while also providing stability for the patient in that sideline position. And then next slide. And so this is just another study talking about the clamshell and how it still has that high percent MVIC of the glute med. And so it was actually included in the top 5 exercises that produced a greater than 70% MVIC. And this was just another study that talked about how these exercises are very challenging. It wouldn't be appropriate for initial strengthening in patients who may have a weak core or not as much stability, but they said that the clamshell is an exception for this because it provides that stability by allowing the patient to lie on the floor, as you can see in the picture on the right. And so, so even though other exercises may have more activation of the glute med, as physical therapists, we should know this, that it's important to consider functional demands and dosage when selecting an exercise for muscle training and strengthening. So just when you're working with a patient in the early rehab setting or a patient who's deconditioned, starting with a clamshell is good because you're still getting that glute med activation, but in a more stable position. And next slide. So the regression and progression for clamshells. So for the regression, we just changed the position. So in a seated position to where you're now moving in a gravity eliminated position. And so you could put a resistance band around the knees, and then you're just still doing that same clamshell, moving the knees out while keeping the feet close together. And studies also showed that this still has activation of the glute med, just in an easier position. And then progression. So those past 2 studies and some of the other research articles we found, they would progress the clamshell kind of like this top right picture, where it kind of is turning into more of a side plank with more just raising the leg up into hip abduction. And so this just requires more stability. So now you're bringing in stability of the shoulder, of the core. You're also requiring that opposite glute med to be activated to help control the pelvis while lifting the leg. So it's really just bringing in more stability. And then these studies also showed that these types of progressions of the clamshell had higher percent MVIC of the glute med when you change the position of the clamshell. And then we also progressed it by just adding a weight to performing the typical clamshell. So just having a weight resting on the thigh. And next slide. And this is just the research behind all of the information for the hip abductor exercises.
All right, so now we're going to transition to the knee joint. This comprised of the tibiofemoral joint and the patellofemoral joint. So the joint is made up of tibia, femur, and patella. The knee is a large hinge joint moving in flexion and extension only. The femur has 2 large condyles in which the medial condyle protrudes more inferior than it does lateral. The lateral condyle also projects more anteriorly, and this helps guide our knee into the locking mechanism. The tibia consists of 2 condyles and 6 facets, with the medial aspect slightly larger than the lateral. The lateral condyle consists of thicker cartilage to withstand outside forces that can impact the lateral knee. And then we have our patella. It's a sesamoid bone that has 2 facets and 1 odd medial facet. It is encased in the thickest cartilage in the body, and it aids in increasing the lever arm of the quadriceps. The patella will glide over the femur when the knee goes from full flexion into extension, and it will lock into place in order for the extensor mechanism of the knee to occur. And just here's some great pictures of that patella with the odd facet and 2 other facets. And then here on this picture, you can just see how the medial aspect of the femur projects more anteriorly. Our knee joint capsule has many reinforcements that protect and support it. As you can see in this chart, anteriorly you have some connective tissue reinforcement, patellar tendon, extensor retinaculum, and then each part of the capsule also has some type of muscle tendon reinforcement. So I'm not going to read the whole thing, but as you can see, there's a bunch of things that are encased or encase this knee joint capsule that can become a problem if extreme motions occur at the knee that are not protected, right? And then our thigh musculature that acts on the knee. So these musculature or the muscles of the knee are found most likely on the anterior, posterior, and medial thigh. Then we also have 2 muscles that act on the knee that are found in the posterior leg as well, which would be the gastroc and popliteus. So we all know that our quads are a huge knee extensor group. The hamstrings are a powerful knee flexor group. Our sartorius aids in hip flexion, slight abduction, hip external rotation, and it also plays a role in knee flexion once the knee is already in flexion. The gracilis aids in hip adduction, internal rotation, and flexion, with also some slight knee flexion if the knee is already in flexion. The popliteus plays a huge role in unlocking the knee joint by externally rotating the femur on the tibia. This occurs once the knee goes from full extension into knee flexion. So it also aids in pulling the lateral meniscus posterior during knee flexion to prevent its own crushing during knee flexion. So all of these muscles are playing a huge role on the knee joint. All right, so here are the ligaments that are supporting the knee joint capsule. The ACL has 2 bands, an anterior medial band, which is tighter in flexion, and then a posterior lateral band, which is tighter in extension. The ACL's main role is resisting anterior translation of the tibia. It also prevents hyperextension of the knee and rotary stability. And then again, you can do the anterior drawer test checks for that integrity. Then you have your posterior cruciate ligament, or the PCL. It resists or prevents posterior tibial translation on the femur, and then it also provides rotary stability. And then again, you can do the posterior drawer for this ligament. Then you have the medial collateral ligament, MCL, which is an intrinsic ligament of the knee. It is flat, broad, it has superficial and deep layers, and then it attaches to the meniscus, the tendon of the semimembranosus, and the posterior medial joint capsule. And so the MCL's main role is preventing restraint of valgus. Then we have our LCL, which is the lateral collateral ligament, which is extrinsic, not to be confused with the MCL, that is intrinsic. So our LCL attaches to the lateral epicondyle and the head of the fibula, and it blends with the tendon of the biceps femoris. And then this plays a role in 50% restraint to a varus motion. And then we have our meniscus, which is a crescent-shaped fibrocartilage. It connects anteriorly by the transverse ligament and posteriorly by the coronary or the coronary ligament. So this meniscus has blood supply to the peripheral edges, again, so poorly vascularized, more medial, which again, with injury can be related to long healing times. So our medial meniscus is an oval shape, and it is broader posteriorly, and it's less mobile. And then our lateral meniscus is more of a circular shape, more mobile, and it's attaches to the lateral capsule. And here is just a summary of the primary and secondary restraints to each of those ligaments, and then what motion that they inhibit. All right, and then here's just some knee joint nerve knee joint nerve involvement. Again, we've seen these nerves quite a bit. Femoral nerve running anteriorly to the thigh, sciatic nerve running posteriorly, and then coming off of sciatic will be your tibial nerve, and then off of tibial nerve will be your common fibular nerve, which is running right around the fibular head. So we have to be mindful of that if there is some numbness, tingling, anything that is occurring at the knee. And then here are just some common pathologies of our knee joint. Again, we talked about all of the ligaments. Any of those can be injured. These two pictures on the right show the anterior George test on the top and the posterior George test on the bottom. We can have inflammation of the bursa at the knee, meniscal tears, knee osteoarthritis, and total knee replacements are a big role in PT rehab. We see those quite a bit. Then you can have patellofemoral pain, patellotendinitis, and hamstring pain, or strain, sorry.
Okay, so the first exercise we're going to look at for the knee is knee extension. We're specifically going to look at rectus femoris, vastus lateralis, vastus medialis, and vastus intermedius. Specifically for this research, I found a lot on vastus lateralis, vastus medialis, and then a little bit of rectus femoris. So the next couple slides will really focus on those muscles. The exercise we wanted to look at, specifically targeting these muscles and knee extension, was the short arc quads. You're going to start your patient in supine with knees extended, place a small bolster under their knee that you're working on, and they're going to slowly straighten their knee until the leg is fully straightened or extended, and maintain contact with the bolster at all times during this exercise. They're going to tighten their quad muscle as their knee straightens, and they're going to hold this straight position for 3 to 5 seconds, and then slowly return to the starting position. The research that I found, and with clinical experience, about 10 to 15 repetitions and then 2 to 3 sets of this exercise. And then for our short arc quads and just knee extension exercise in general, this may be needed due to knee injury or knee surgery. It also has a significant impact on activities of daily living like walking, squatting, and stair climbing. And then failure of voluntary contraction, not muscle loss cross-section, accounting for quadriceps weakness in muscles following total knee arthroplasty. And I found that in an article that is listed below. The lateral malalignment of the patella resulting from an imbalance between the vastus medialis and vastus lateralis is to be considered the main cause of patellofemoral syndrome, which was mentioned earlier. But it also plays a big role in how those muscles balance out and how knee alignment is affected because of those muscle imbalances. And you also really want to focus on this to prevent knee injury or further knee injury. Again, like malalignment of the knee, specifically during sports or other athletic activities, or even just running, can cause wear and tear on your knee and cause some pain. So you just want to make sure these muscles are strengthened appropriately, so you do get that proper alignment. Next slide. So looking at some research, I first found one that talked about the vastus medialis activation during knee extension exercises, specifically looking at straight leg raises and weight-bearing activity, comparing the two. So they were looking at EMG amplitudes for vastus medialis expressed as a % maximum voluntary asymmetric contraction. They did have 15 subjects. So they found that the straight leg raise had a greater activation than the single leg stance and bilateral squat exercise, as you can see on the screen. And the step up and unilateral leg press exercises had the greatest activation. Straight leg raise performance, because of what they found in this, can be an important indicator for exercise progression and even weight-bearing activities. So especially if you're doing this in an inpatient population where someone just had knee surgery, being able to have them perform short arc quads and then maybe progressing to single leg raise can show that they are ready for weight-bearing activities, specifically like step ups, step downs, and unilateral leg presses and bilateral squats and stuff like that. So their purpose of this whole main study was to compare the vastus medialis activation during a straight leg raise to 6 commonly prescribed weight-bearing knee extension exercises, and to determine if the relative activation among a sequence of weight-bearing knee extension exercises. So their post-hoc analysis revealed the unilateral leg press and step up generated the greatest vastus medialis activation compared to the bilateral squat and the single leg stance at 0 and 30 degrees of knee flexion. The step down, single leg raise, bilateral squat, and single leg stance at 30 degrees of flexion had significantly greater vastus medialis activation than single leg stance at 0 degrees of knee flexion. During the single leg raise exercises, the subjects generated an average vastus medialis activation of 26%, which you can also see on the screen. And with this, the researchers, like I mentioned earlier, determined this could be an exercise to determine or a clinical indicator for initiating weight-bearing activities. And excuse me. And actually, that's all I need to talk about with this. Next slide, please. So for this one looked at EMG analysis of vastus medialis and vastus lateralis across straight leg raise, short arc quads, medial tibial rotation, and hip adduction in normal individuals. Specifically, this was looking at how it relates to patellofemoral syndrome. None of the subjects did have patellofemoral syndrome, but we did find that strengthening the whole quadricep femoris does not help improve lateral muscle imbalance, but vastus medialis should be selectively strengthened to increase dynamic stabilization of the patella using rehabilitation exercises which stimulate a discriminatory training effect on vastus medialis over other quadriceps muscles. So basically, strengthening the whole one does not really help alleviate that muscle imbalance. You're definitely going to want to focus on vastus medialis for strengthening really that stabilization when you are doing movements and different exercises. They had 10 male occupational workers, and all resistant exercises resulted in higher vastus medialis activity in comparison to vastus lateralis activity. And vastus medialis activity was not significantly higher than vastus lateralis activity for each of the 6 rehabilitation exercises, and they found no significant difference in the ratio of vastus medialis versus vastus lateralis in all rehabilitation exercises. But I did want to point out hip abduction was significantly higher in the straight leg raise in neutral, the straight leg raise in external rotation, and the medial tibial rotation for vastus medialis. So you definitely want to focus on, and what that really points out is this is minimizing the lateral pull on the patella by activating the vastus medialis and the strong hip abductors, providing a stable origin for vastus medialis. So in relation to that, for the patellofemoral syndrome, balancing out those 2 muscles, specifically lateralis and medialis, will help decrease that incidence of that occurring. I did want to point out for this specific study, when you're looking at short arc quad in neutral and short arc quad in external rotation compared to straight leg raise, it is higher. But when looking at the pictures, they had their patients positioned, or participants, excuse me, positioned in lying position with their leg extended in the air, so in full knee extension, no higher than the contralateral knee, which to me kind of already puts you in an isometric contraction of specifically those knee extension muscles, vastus medialis and vastus lateralis to be specific. So I kind of don't know how to compare that really to a straight leg raise, because that's not typically how we do a short arc quad. So I just did want to point that out when you are looking at these numbers. Next slide. This next research article focused on EMG activity of the gluteus medius, gluteus maximus, biceps femoris, vastus lateralis, vastus medialis, and rectus femoris during the monopodal squat, forward lunge, and lateral step-up exercises. I thought this was a great exercise because we are doing hip and knee, and it kind of puts, it combines both of them. And it's typical exercises we would see in clinic. So they had 10 men and 10 women. Their participants performed 5 repetitions at 60%, which is a 5 repetition maximum in each of the evaluated exercises. And they found that the monopodal squat exercise showed a higher EMG activity in relation to the lateral step up and forward lunge exercises in all of the evaluated muscles except for rectus femoris. This showed a significantly higher EMG activity only in the forward lunge, rectus femoris did, which you can see in these graphs. Higher EMG activity in all of the muscles during the concentric phase. But I did want to point out when they talked about it later in the research article, they did mention that this could be due to the lower speed of muscle fiber conduction during eccentric actions compared to concentric. And normally the angular speed at which the eccentric phase is executed is lower than concentric. Specifically, we've talked about going slower for eccentric, you get the most out of it, especially if you want to maintain adequate execution of the technique and prevent possible musculotendinous lesions or injuries. So this could be why it resulted in a lower EMG activity of the eccentric phase. And of the 3 evaluated exercise, vastus lateralis and vastus medialis showed the highest EMG activity, followed by gluteus medius and gluteus maximus, and then lastly, rectus femoris. Squats performed in one leg are an adequate exercise primarily for the activation of the extensor and stabilizing muscles of the knee, as well as the stabilizers of the hip. So again, I just wanted to point this out so you can specifically see how vastus medialis and vastus lateralis were drawn out for these specific exercises. They are, to me, knee-focused exercises, but they can also strengthen the hips, specifically squats too. You are definitely going to work your hip muscles when you are doing a one-leg squat, but I did think this was a great illustration of some knee extensor muscles in specific exercises. Next slide. So some regressions and progressions of the short arc quad, specifically based off of clinical experience and the research that I just mentioned. So for regression, you're going to want to do the quad set. So you're going to place a towel under their knee and instruct the patient to press the towel towards the table. And it's really just kind of an isometric contraction, but that towel underneath them will give them a really good cue of what they should specifically be doing. So they are cueing the right muscles. And then a progression based off of the research. So you could do some long arc quads, like the picture in the top right corner. You can add resistance bands like it shows. You can add ankle weights. And moving on, you can do a straight leg raise and add weights to that. You could also do a leg press. And I wanted to point out that leg press elicited the greatest EMG activity for quadriceps muscle complex, but specifically shown in the greater knee flexion angle. And vastus lateralis and vastus medialis elicited the greatest muscle activation during this leg press exercises, specifically with 2 feet on the plate. And then this was also followed closely by the rectus femoris. So if you want to even progress that further, like I talked about earlier with the monopodal squat, you could do one leg presses as pictured too. And then you could also focus on step up and step down exercises, as those also do still work the knee extension muscles. You can also do a forward lunge, and then again, a monopodal squat just on the ground. Next slide.
All right, so looking at the movement of knee flexion, we chose to focus on the assisted Nordic curl. This exercise targets the muscles of the hamstrings, which is the biceps femoris, semitendinosus, and semimembranosus. The assisted Nordic curl can be performed using a cable machine or a therapist assisting by holding the resistance band, depending on what you have available to you in the clinic. It is important to note that the reason we are doing an assisted version, and I will go into this in more depth later, but there's an immense amount of research supporting the Nordic curl as like the best exercise to strengthen the hamstrings. But that exercise is incredibly intense and really meant for high-level athletes. So to make it more applicable and more reasonable to apply to our patients in the future, we've chosen to focus on the assisted version and use the traditional version as a progression. But so when you're instructing the assisted Nordic curl, you're going to ask the patient to kneel on a pad just to support their knee. And then you're going to have their ankles held in place either by a partner, a tech, or hooked on some kind of immovable object, because if not, then they're not going to be able to perform this exercise. Then you're going to want to place the resistance band across their chest or shoulders, whatever's most comfortable, so that it's not going up towards their neck and not so far down that it's not giving the assistance that is required of it. And then you're going to instruct them to lean forward in a slow and controlled manner and make sure that they're moving just from the knee joint and keeping the hip stabilized in a neutral position. We do not want any movement coming from the hip joint because that defeats the purpose of the benefits for the hamstring muscles. The subject should keep their arms crossed over their chest when lowering their body down. And then when they reach the floor, they should uncross their arms and use them to push them back into a starting position after reaching the floor, so that we're really focusing on the eccentric movement. When prescribing a dosage for this exercise, in one of the articles I have listed, the article's title is "The Minimal Effective Dose of Nordic Hamstring Exercise for Reducing Hamstring Strain Injuries in Football/Soccer." It indicates that values as low as 2 sets of 3 reps once a week, or as high as 3 sets of 10 reps twice a week, as a starting point, can still be effective as long as you're adding linear progressions after it. So really, it's important to see what kind of level your patient is at, how well they can tolerate the exercise, and then go from there, as well as factoring in the amount of assistance that you're giving. So the amount of resistance the band is providing the subject. So going into some of the clinical applications, I'll go into a few of them in more depth in the next few slides. But if you're looking at the second one there, the purpose of this study was to investigate the effects of a Nordic hamstring exercise training program on the many hamstring injury risk factors. So this is kind of focusing on the preventative aspect of performing this exercise. And so the group that performed the training program with this exercise showed a higher % changes in hamstring isometric peak torque, eccentric peak torque, eccentric work, and functional hamstring to quadriceps torque ratio, as well as the program also led to an increased fascicle length and reduced pronation angle in the biceps femoris long head, and did not have significant changes on the muscle thickness. So basically, what they concluded is that this short-term Nordic hamstring exercise training program, which was 4 weeks, but I think 2 sessions a week, it helped to counteract many of the hamstring injury risk factors that are present in active young adults. So again, remember that this was performed on active young adults, so that may not always be our patient population, but still the benefits were described very well there. And in the fourth research article shown there, they found that the Nordic hamstring exercise actually showed small improvements in sprinting performance in football players and showed large increases in peak eccentric hamstring strength and capacity. So especially that's more for your sports specific, getting back to sprinting, but this has been shown to show like significant improvements. And then the fifth article there, it also suggested that the Nordic hamstring exercise program can significantly reduce the incidence of hamstring strains in football players. And so then they kind of concluded that it should be implemented into weekly programs. And they couldn't really find a minimal effective dose but they suggested multiple ways for future research to be done. So if you wanted to include this into a training program, you would definitely want to get an update on the most recent research. And there's just a few pictures of the different ways that you can set up the assisted resistance. All right, next slide, please. So this graph is from the article Muscle Activation Difference During Eccentric Hamstring Exercises. And they compared the stiff leg deadlift, a unilateral stiff leg deadlift, the Nordic hamstring exercise, and a ball leg curl, like a Swiss ball leg curl, while measuring the activation of the 3 muscles of the hamstring group with surface EMGs while the subjects performed the exercise. Their subjects were healthy participants, so not specifically athletes. And in both male and female, you'll see that the top graph is the female participants and the bottom graph is the male participants. Both populations showed a difference in, or showed that the Nordic hamstring exercise had significantly higher muscle activation of the hamstring group than any of the other exercises. And you can see that the first 3 columns are the different muscles for the Nordic hamstring exercises, and it's significantly more than the other exercises. And this is based on the EMG activity of the percentage of their maximum isometric voluntary contraction to kind of give it like a baseline. They had measured that maximal isometric voluntary contraction before the protocol to make sure that they were making this relative to each subject. And when looking at the difference in the actual muscle activations in the Nordic hamstring exercise, they found that the semimembranosus activation was significantly lower than the biceps femoris and semitendinosus. That wasn't shown in any of the other exercises, but it was suggested in the article it could be due to the size of the muscle or just a variation, because that wasn't supported in other research done by other studies. Basically, this data indicates that the Nordic hamstring exercise would be the most effective for the hamstring muscles, but due to its high intensity nature, it would be hard to start a subject out on this if they're not an athlete. So they also suggested that other exercises that was described here could be useful at the beginning of a strength training program, as they lead to lower muscle activation and the patient or subject may tolerate them better. Next slide, please. So these charts came from the article Kinetic and Electromyographic Responses to Traditional and Assisted Nordic Hamstring Exercise. And basically what they did was they compared the Nordic hamstring exercise under multiple levels of assistance versus the traditional exercise that is performed unassisted. So this is kind of where we got the idea that we could incorporate all the benefits of the Nordic hamstring exercise, but making it more reasonable for our populations that we are likely to see more often in the clinic setting, to make it assisted. Because, well, with this research article, they actually used subjects that were professional soccer players. So you're gonna have to keep that in mind when looking at all these results. It's not exactly performed on the population that we will be most likely seeing, but it was the first to kind of look at this exercise in varying assisted levels. And so it really was like the first of its. I would definitely keep an eye out for more research like this, but with different populations. But still, it's very valuable information. So they used the different assisted loads by applying it with a Kaiser machine, which from what I can tell is similar to your basic cable machine. And all of the assisted conditions demonstrate a significantly lower relative eccentric knee flexor strength compared to the traditional exercise. this relative strength was normalized from the peak eccentric knee flexor force relative to the subject's own body mass. So you can see that on the left, I included the relative one, so you can kind of see based on the subject's body mass as well. So it's kind of more consistent to be able to compare and contrast. And you can see that there was significant difference in the force produced as you add more assistance during the exercise. And what's most significant to me is that they also took the rating of perceived exertion during this exercise. And so for each loading condition, the RPE was significantly lower as the amount of assistance was increased. And except for the difference between the 10 and 15% assisted conditions did not show to be significant. But besides that, you can see, because the biggest problem with this exercise is how intense and hard and fatiguing the traditional Nordic hamstring exercise is. So to show that even applying a little bit of assistance can decrease the RPE that much makes it a lot more feasible for lower level populations, and especially if you do a bit of training beforehand. All right, next slide, please. So this is from the same article, and I just wanted to put it there for y'all to see like a more simplistic version, straightforward. But basically it just shows the different conditions with the different amounts of loaded assistance and the mean relative knee flexor strength. So you can see in the percentage. So you can see that it's still a pretty high percentage of their max knee flexor strength that you're getting with these levels of assistance, and including that they had significant decreased RPE. So you're getting still a significant amount of strength produced and worked on, but making the exercise feel a lot less intense and less difficult. So that really, to me, made it much more feasible for a lot of the populations that we will be seeing in clinic. Next slide, please. So it's important to note as well that the surface EMG signal was taken from the biceps femoris and semitendinosus in that protocol as well. This is from the research article, same research article as the past two slides. These results show that there was no significant difference in the muscle activation ratios or neuromuscular contribution across the different loading conditions. And overall, there wasn't much significance in the variability of the surface EMG between the biceps femoris and the semitendinosus. So pretty even, or mostly even contribution. And so looking at that data, it was concluded that there was no evidence to suggest that changing the assistive load would change the ratio of biceps femoris to semitendinosus activity, and therefore there would be no change to the activation balance of the hamstring muscles. And this would imply that subjects could train at varying assistance levels with a perceived lower intensity while still maintaining a high level of hamstring activation. So really with this as well, they're showing that you're making the exercise seem easier to the subject while also maintaining that high level of hamstring muscle activation. So you're still getting a lot of the big benefits that are so supportive of the traditional Nordic hamstring exercise, while taking away kind of that intensity that is a negative factor of it that makes it so hard to subjects. So then you can make it more feasible for the people you will see in your clinic. All right, next slide, please. So to regress this exercise, looking at that first article that compared multiple exercises, we chose the supine Swiss ball hamstring curls, because when looking at the stiff leg deadlift, it requires a lot more factors that someone in your patient who may be may not be able to perform the form quite properly and get the technique right. So the supine Swiss ball hamstring curls we thought were a better option if you're trying to regress this exercise. And then to regress it even more, if a patient is not able to tolerate the supine Swiss ball hamstring curls, you can have them do stool scoops, which is when they're sitting in a chair and like straightening one leg, placing their heel on the ground and pulling with that leg to move the chair forward. I would like to note that you do pull with your legs and not push, moving the chair backwards, because I saw quite a few things online that said pushing it backwards was working the hamstrings, which it's not. So just make a note of that, but that really isn't that functional of a movement. So you would want to progress them out of that as soon as they are able. And then to progress our exercise, we went ahead and said to go fully with the traditional Nordic hamstring curls, unassisted or with weights. Again, this is a really intense exercise and with many benefits that have been proven through much research. So if they can get to this point, it's definitely beneficial to work with them and get them to be able to perform this multiple times. And like what we said with that article that looked into the dosing, you don't have to get like a minimum level of 10 reps a week or something crazy. Just start them where they can start. And as you progress, you'll still get the benefits that you're looking for as long as you keep them progressing. But yes, that's it. Next slide. And then here is just all the articles that were specific to the knee flexor exercise that we described.
And then here are our references for the entire project. Thank you guys for listening.